Looking for a quick breakdown on bowel dysfunction in individuals with SCI? Look no further. In this video, I'll simplify everything you need to know about bowel dysfunction from an OT perspective. We'll cover two main types of bowel dysfunction in SCI populations and key management strategies to enhance your practice and improve your clients' quality of life. Let's dive in. Welcome back to video number 3 in our series, where we explore the role of OT and BBM. I'm Julia, and today we're diving into neurogenic bowel and key guidelines for bowel management. Extra resources are linked in the video description below for a deeper dive beyond what we'll cover in this video. If you're already familiar with the basics, feel free to skip ahead to video 7, where we focus on OT assessment and intervention strategies for bowel management. With that, let's get started. The bowel system is a key part of the digestive system, made up of the small and large intestines, also referred to as the colon, the rectum, and the anus. The small intestines absorb nutrients from food, while the large intestines absorb water and form stool for elimination through peristalsis, wave-like muscle contractions that move waste through the digestive tract. There's no universal normal for bowel movements, but research suggests going at least 3 times a week is considered healthy, with stool looking like at least a type 3 or 4 on the Bristol stool form chart. Now, the term neurogenic bowel is used when the nervous system's control over bowel movements is disrupted due to an SCI. There are 2 key pathways that regulate bowel movements: the rectal anal inhibitory reflex, or RAIR for short, and the brain and spinal cord pathway. RAIR is one of several sacral reflexes that regulate bowel function. This automatic reflex forms a communication loop between the rectum and the spinal cord. When stool enters the rectum, stretch receptors trigger this reflex, causing the internal anal sphincter to relax and creating the urge to go. Next, we have the brain and spinal cord pathway. The pontine defecation center in the brain regulates voluntary control over the external sphincter, allowing bowel evacuation at an appropriate time. In other words, it suppresses the RAIR when needed to delay a bowel movement. When these pathways are disrupted by SCI, neurogenic bowel function either becomes reflexive or areflexive, based on if the sacral reflex arc is still intact. Now, unlike bladder management, where catheterization is the gold standard, bowel management is different. The approach to managing each type of bowel dysfunction varies, so pay close attention. Let's start with reflexive bowel, also known as spastic bowel. This occurs at upper motor neuron lesions at or above T12. In this case, the RAIR is still intact, but the brain to spinal cord connection is lost. This leads to 2 main challenges: retention and incontinence. With retention, uncoordinated contractions of the rectum and the external sphincter prevent full evacuation. Stool that sits in the colon too long can harden over time and increase risk of constipation and impaction. Meanwhile, incontinence can also be an issue, as the rectum can contract unpredictably and cause involuntary bowel movements and cause secondary issues like skin breakdown. So how do we tackle these challenges? The goal is to optimize reflex activity to help initiate bowel movements, following a scheduled bowel program. To trigger said reflexes, we use methods like digital stimulation or suppositories. Additionally, medications like stool softeners and osmotic laxatives and eating a high-fiber diet can regulate consistency and movement. Moving on to areflexive bowel, or flaccid bowel, seen with lower motor neuron lesions below T12 or direct damage to the sacral segments S2 to S4. In this situation, the RAIR is lost and voluntary control is also lost. Again, this situation brings 2 main challenges, but for different reasons than before. The first being retention. Without reflex activity, stool slowly accumulates due to reduced peristalsis and weakened rectal contractions. Left untreated, this could lead to impaction. And secondly, incontinence. Due to a loss of external sphincter tone, stool can continuously leak and lead to skin breakdown. So, how do we address this? Unlike the first scenario, due to the absence of sacral reflexes, we use manual evacuation or enemas to remove stool. And of course, diet, hydration, and medication adjustments can help regulate stool consistency and movement. Why does this matter for OTs? Understanding bowel dysfunction helps you explain to a client why they may be struggling with your bowel management program and how to help them manage it more effectively. Beyond that, you can empower your client with prevention strategies, whether it's adjusting evacuation techniques or guiding them to discuss medication options with their provider. Now, in case you missed my previous video on neurogenic bladder, I'm going to throw a curveball and talk about spinal shock. If you recall, immediately after an SCI, the body goes into a temporary state called spinal shock. This is where reflexes, movement, and sensation below the level of injury shut down. This can last anywhere from days to weeks until you start to slowly see a gradual return of those reflexes. How do we know when spinal shock is over? The return of sacral reflexes. Healthcare providers will routinely check for these reflexes like the bulbocavernosus reflex, or BCR, or anal wink reflex, as these are the first ones to start returning. So what does this mean for the client? Until spinal shock resolves, regardless of injury level, all clients will initially present with lower motor neuron, areflexive, flaccid bowel. If the injury is at or above T12, resolution of spinal shock may result in a transition to reflexive bowel. However, until this happens, our focus remains on meeting the client where they are, maximizing independence and adapting their bowel management program as needed. And one more note, this time on autonomic dysreflexia, or also known as AD. For individuals with injuries at or above T6, bowel movements can trigger AD, which is a life-threatening condition caused by an overactive autonomic nervous system. Signs of AD include, but are not limited to, a sudden spike in blood pressure, slow heart rate, a pounding headache, and flushing and sweating above the level of injury. If you suspect AD during a session, stop what you're doing right away and sit the client upright to lower their blood pressure, check for a blocked catheter, full urine collection bag, or other noxious stimuli, and if symptoms persist, get medical attention right away. Understanding AD allows us to respond quickly and educate our clients on how to prevent it. All right, now that we've covered the basics, let's talk about some general bowel management timelines and guidelines. As previously discussed, when individuals with SCI arrive in acute care, their bowel management programs will consist of manual evacuation techniques due to spinal shock. By the time they transition to inpatient rehab, their bowel management program continues to evolve under our care. While every bowel management program is highly individualized, general strategies in inpatient rehab include scheduled bowel movements, progression to a seated position, diet and hydration education, medication management, and of course, continuous monitoring. For scheduled bowel movements, program schedules can vary between hospitals, but they typically occur daily or every other day. Early on, these sessions may take 1 to 2 hours as the routine is being established. However, with consistency, the process becomes more efficient. Even for individuals with years of experience managing SCI-related bowel care, sessions can still take about 30 minutes per program. For body positioning, initially, bowel programs will take place in a left side-lying position due to a lack of trunk control. However, you want to progress to a seated position on a rolling shower chair or a 3-in-1 commode to take advantage of gravity. For diet and hydration education, encouraging proper fluid intake and high-fiber diets can promote healthy digestion and regular movements. For medication management, you can support clients in self-advocating for the right bowel regimen, whether that includes stimulants, laxative, or enemas based on their individual needs. And finally, ongoing monitoring is key. Clients should know that bowel management programs can always be adjusted as needed. Teaching them to recognize signs of complications like prolonged constipation ensures long-term success. That was a lot if you're new to bowel dysfunction and management. So here are 3 key points to remember. Scheduled bowel movements daily or every other day is key in neurogenic bowel management. Knowing the difference between reflexive and areflexive bowel helps determine the most effective stool evacuation method for each client. And finally, preventing secondary complications like impaction or skin breakdown associated with retention or incontinence is critical for long-term health. Okay, now that we've covered the foundations of both neurogenic bladder and bowel, time to move on to assessments and interventions. See you next time.